Welcome everyone back to the 2023 CME. This month we are going to be discussing environmental injuries, specifically cold-related injuries.
We run into these a decent amount in the Yukon, although not as much as I would have expected before I lived up here. Most people are prepared.
Yes, it's one thing about living in the Yukon. If you're not prepared, the Yukon makes it very aware that you're not prepared.
Yep. All right, a couple of world records. Anna Bagenholm, probably butchering that last name,
Probably.
held the record for the adult with the lowest body temperature to survive to full recovery. What's key about this is super rare.
Very rare.
Like, most people are not going to survive this, which is why it's a record. So 13 degrees Celsius, central core body temperature, and the record lowest body temperature ever was 11.8.
That's terrifying. Consider that's colder than most summer days up here in the Yukon.
Here's a quick video showing what happens when you freeze blood.
All right, we're going to delve right into it. We're going to start here with frostbite. It varies in degrees of severity from frost snip right on through to deep frostbite. So we're going to start out with the mildest form, which is frost nip. It generally comes on slowly, tends not to be painful, and can be treated with just placing a warm hand over the chilled part.
We're probably not going to get called for this as being the chief complaint. This might just be something that you notice while you have a patient.
Or in bystanders that are there.
Yeah. Risk factors for frostbite. So, obviously going out in the cold without proper gear. That's going to be a big one. If you have impeded circulation from Raynaud's syndrome, peripheral vascular disease, diabetes, and then the weird one that people don't think about is drinking alcohol. Because it keeps your vessels dilated, it makes you feel warmer, and so you don't notice the cold as much.
So going out in the cold when you're tired, when you're definitely, if you're not properly hydrated, because as you exhale, you blow off a lot of water vapor, and hungry because you're not regenerating your fat supplies that you're burning, trying to stay warm. Coming into contact with cold objects, just sitting on a cold object makes you susceptible to frostbite because you're losing heat to that object. And allowing yourself to be thoroughly chilled, meaning you realize you're cold, but you want to stay out longer anyways, so you ignore it.
Yeah. Let's talk about superficial frostbite. The most common
common symptoms are altered sensation. So as the part becomes chilled, you lose that tactile stimulation. It'll take on the white, waxy color that's as your skin begins to freeze.
It'll be firm to palpation,
Yep.
but at the same time, it'll still be movable because the stuff underneath hasn't frozen yet. It's just the skin on top. And then once it starts to thaw, you're going to see some cyanosis.
And so as you've seen in the video earlier on, so as tissue is damaged, cells freeze and they begin to leak fluid, and which produces edema in the frostbitten area.
Yep.
So we're really not going to be doing a whole lot in the pre-hospital environment. The biggest key thing is if you can't get this person out of the cold environment and keep them warm, don't actively start rewarming the person. So get them in the ambulance, crank the heat. You are going to do passive rewarming. So if you're not sweating in the back of the ambulance, it's not warm enough. All right, you're going to expose the areas. If they're wet clothes, get them off as quickly as possible. Cover them with some warm blankets. And if you can use heat packs, use them in the non-dependent areas to allow for passive rewarming. We do not put frozen parts onto the radiators or any direct heat source in the back of the ambulance.
The big thing is here, we're going to transport them because definitive treatment is at the hospital.
Yep.
And ours is all passive.
All right, moving in now into deep frostbite. So these are usually involve the extremities, okay? Skin will go from a white, yellowish white, even to a molten bluish white color. The skin definitely becomes hard, cold, and they will lose sensation. So the major tissue damage is from the thawing process itself.
They think, they're pretty sure that a lot of the problem is decreased circulation. So when you get the swelling and you get the frozen, there's not enough blood going through, and that's when it goes into gangrene. Yeah. And that's why a lot of the focus now is on decreasing the swelling.
So treatment for frostbite does not differ greatly from superficial. The key component is get these people to the hospital.
Here's our frostbite guideline.
Yep.
It's pretty simple. We don't really get into all the different options. We just go partial thickness, full thickness, and then how far are you from the hospital? Those are the big parts on this one. Here, and the other thing is our goal is to make sure it doesn't refreeze.
Yep.
We can't really fix the problem in the ambulance. We can only make sure it doesn't get worse.
And so a little trick for you guys. You might not get a SpO2 reading on the affected limbs simply because all the blood has been shunt from the core.
You're not going to get an SpO2 on these guys.
Not in an area that's been frozen. So
yeah, if there's a limb that wasn't affected, you can get an SpO2.
Yep.
But odds are good you're not going to get a good reading because they're probably also hypothermic.
Exactly.
Same with the glucometer. You're not going to get a glucose reading on these guys. Their capillary blood vessels are all constricted, even in the non-frozen limbs. All right, so take a few minutes to practice your assessment and come back after that.
Yep. All right. So now we're going to switch over into hypothermia. So it's a decrease in the central body temperature starting at 35 degrees. So
the big thing for us is we can't get that in the field.
No.
Like at the CCP level, we technically can, but we're not even doing that unless they're already in the hospital.
Yeah.
It's not something we're doing. So we're going to go off of symptoms, as you'll see in a little bit.
All right, in this next slide, it depicts some of the signs and symptoms that a person will experience as their body core temperature begins to drop. And remember, these temperatures are based off body core temperatures, not tympanic or oral temperatures either.
Yep. Risk factors. A lot of the same risk factors as frostbite.
Yep.
Obviously, cold temperatures. You want to make sure you have the right PPE on to go outside. Fatigue, improper gear. When you get wet while you're outside in the cold, you tend to have evaporative cooling faster, and that causes hypothermia. We talked about the dehydration. It's the same concept.
Yep.
And malnutrition, length of exposure. So the longer you are outside, obviously, the more heat loss you're going to have, and then how cold it is.
Yep.
You're going to have less of a chance of hypothermia at 10 below if you're wearing the proper gear than if you're wearing the proper gear at 50 below.
Yep. So we've discussed it earlier on, but we're going to go back into it. Alcohol is one of the most common causes of heat loss in an urban setting. It impairs shivering, which produces your heat. It causes your blood vessels to dilate. And if you have advanced liver diseases, your glucose stores are below normal, so your body doesn't have those ability to tap into those resources to generate heat. And like anything else, it impairs your judgment.
Alcohol is a big problem for hypothermia. I've seen a lot of hypothermic patients who were drunk first.
Oh, yeah.
Older people are another common source of hypothermia. And these ones can actually happen in houses.
Yes.
For a couple different reasons. One, they have trouble generating heat effectively. With the reduced muscle mass, they aren't able to shiver as much. When they have atrophy of the subcutaneous fat tissues, they don't have as much insulation. And then a lot of times, if they're on a restricted budget, they'll actually keep their houses colder than they should be, trying to save money.
And so some of the other things, they may be on medication that prevents vasoconstriction. And then let's delve into some trauma. So hypotension and hypovolemia, they just don't have the ability to pump blood out to the extremities, or it's reduced. So trauma to the central nervous system may prevent shivering, and it may actually lead to coagulation problems within the system as well.
Which decreases blood flow, which causes hypothermia.
Yep.
You can actually get hypothermia from some of the procedures we do as well.
Oh, yes.
When we cut off people's clothes, that introduces them to a cold environment. Something to think about.
Yeah, just the stress of taking someone up in a plane. Yeah. Taking them up to a higher altitude. It's colder up there. So, while we get back into this, so watch out for the umbles. The stumbles, the mumbles, the fumbles, grumbles. Okay? All of these indicate cognitive impairments.
Yeah. And like I said, we can't measure their temperature, so we're using a lot of our assessment to figure out how bad this is.
So the clinical picture of hypothermia. So your cardiovascular system. So as you become cold, we all know body shunts blood back to the core. So your body interprets this as an increase in blood volume, and the way it responds is it produces urine, and you pee a lot more. So it's trying to drop that blood volume. As blood becomes thicker as it becomes cold, and it impairs circulation, thus accelerating the hypothermia. As you become colder, initially your heart speeds up, and then it begins to slow down, and it begins to affect the electrical conduction system within the heart. So you will never be able to tell this, but when your body core temperature reaches 32.2 degrees, you can expect cardiac dysrhythmias, most common being a bradycardia. And then as a temperature reaches 28, you can expect ventricular fibrillation. This is why we tend to focus on not to handle these people very roughly, because even the slightest stimuli can trigger a dysrhythmia.
It's a big vicious circle.
Oh, it's horrible.
The muscular system, it's going to slow down in response to the cold. Initially, you're going to have shivering, but that's eventually going to stop. When the core body temperature is at 32.7, you stop shivering. So if they've stopped shivering, they're cold.
Yeah.
And then as you get colder and colder, your core muscles are going to become weaker and stiffer.
As you shiver, your body burns up glucose stores. Okay? As your insulin levels falls, your body switches to metabolizing fat, which then leads to something called DKA. Liver metabolism of drugs will be slowed down. Will you be able to recognize it or need it at your scope of practice? No. Just be aware that it does happen.
Initially, you're going to see their respiratory rate speed up, and then slowly it's going to come back down. And leads to a decreased minute volume. So when we're bagging these people, we're probably going to end up over-bagging them. You're going to see possibly bronchospasms, so wheezing. You might start to hear some wheezing. At 32.2 degrees, you're going to see severe, profound hypoventilation. They're not going to really have the ability to protect their own airway, and they're not going to be using a lot of oxygen, which is one of the protective measures.
Yep. Once again, we're taking a look now at the treatment for hypothermia.
So you can see here, we've totally broken it down by symptoms.
Yep.
There's no temperature ratings at all. So if you have shivering and a normal mental status, you're going to go down the mild hypothermia route, in which case it's supportive. If you've got some simple sugars like oral glucose, you can give them that. If you don't have shivering or you have an altered mental status, you're going to go down the moderate to severe hypothermia. You're going to be very careful with the patient, and you're going to just transport them.
Okay, one skill we tend to overlook in hypothermia is checking a person's blood sugar. When people shiver, they're shivering to produce heat, and they burn through their glucose stores at a very rapid rate. So always remember, if you can get access to an extremity that hasn't been compromised by frostbite or hypothermia, check blood sugar.
And then treat according to hypoglycemia guidelines.
Guidelines.
There's going to be times when you're going to decide whether or not to do resuscitative efforts, so CPR. In the pre-hospital environment, we obviously, with lethal traumatic injuries, we're not going to treat that.
No.
If they're so frozen as to have solid skin, solid body parts, then you're not going to be able to do compressions effectively, and these people are not going to survive. No. If they had a submersion injury that preceded the arrest, probably not going to be able to resuscitate them, but you can definitely continue to do continue to do CPR on the way to the hospital or the nursing center, and let them decide that at that point. Sometimes the effects of hypothermia protect the brain and organs if the hypothermia happens quickly. Yep. So if you get an immersion in icy waters, for example.
So some of the things to be aware of when you're looking at starting CPR is pulse check. You are going to do a prolonged pulse check, like count for a whole minute.
Yeah.
Their heart rate might be so slow that it may not even be perceivable. And the key thing to people who have been resuscitated to full neurological statuses, they are controlled rewarming, which unfortunately we can't do anywhere in the Yukon. These people will be rewarmed at 1 degree, I think it's per 30 minutes. That's how slowly these people are rewarmed. Mm. So even at the critical care level, we will typically not administer any drugs. We will try it once, one shock, and then that is it. Then we withhold everything until the person has been properly rewarmed.
Other than CPR. You can see that here in the hypothermic with no signs of life in the guidelines, the procedures. The big one here is if there's a shock advised, you're going to give it once, and then you're just going to continue on with CPR. Your goal is to remove any wet clothing to try and prevent further heat loss. We don't want them to get colder again. So we don't really do a lot until we get them in the ambulance. Yeah. All right.
That concludes our discussion.
I have an anecdote.
Oh. Well, I was going to let you throw it in at the end.
I'll do it now.
Okay, do it now.
So I know of a call that I consulted on. Wasn't actually my call, but the crew went to a patient who had fallen outside and knocked themselves out. When they got there, the jacket had been pulled up, and everywhere that was exposed, where the jacket came off, and the hands where there's no gloves, frozen solid. But the jacket insulated the other parts enough to remain semi-soft. And the crew chose not to resuscitate because of the frozen solid parts in the core. And that was the right choice in that case. It was obvious death, and there was nothing they could do. But it was something that they really had to struggle with and think about.
Yeah.
In summary, it's important to remember that for the most part, for cold-related injuries, we don't do a lot of treatment pre-hospitally. And this is true at almost every level. We need to get them into a facility that's got the right equipment for this.
Yep. So if they're on scene, get them in the back of the ambulance as quickly as you can. Get them in the back, remove all clothing that's promoting heat loss. So if they're wet, take it off. snow, remove it, crank the heat in the back of the ambulance. If you're not sweating, it's not warm enough in there. If you can't actually guarantee that you're going to be able to maintain warmth, don't start the process until you can guarantee that you can actively rewarm the person.
If they aren't showing signs of life, handle them very carefully.
Yep. So remember, vital signs are going to take some time to properly check for vital signs. Heart rate's going to be slow. Breathing's going to be slow depending on the severity. So take some time. I know we usually say 5-10 seconds pulse check. Well, here, take the whole minute.
Yeah. And just be ready to transport.
Yep.
That's your goal in this case, transport.
This concludes our discussion on cold-related injuries. Hope you found this informative. Hope you can translate this into your practice. Spend the rest of your night now going through and doing some skills on each other.